This conference will now be recorded.
Okay, Cammie.
Great. Thank you so much, Nicole. And hello, everybody. Thank you for joining in on us today to talk about framing rural health value and part of our webinar series. One of my favorite topics, community, customers, and population health. I'm proud to report that I'm presenting here from Duluth, Minnesota on a summery day. It's not very often that we get to say it's a summery day here in Duluth, but today is one of those days, so I'm proud to report that. Over the next hour, we're going to identify the value of providing excellence in customer service by identifying tools and models and hearing from the Colorado Rural Health Center on how they have incorporated excellence into their programming. We'll also discover and reinforce the importance of establishing partnerships across various sectors aimed towards improving patient outcomes, as well as we'll share with you findings from a population health summit and the creation of a guide that's aimed towards balancing between the volume and value-based reimbursement structures, particularly that of population health. This guide has just been released and is available on the center's website at ruralcenter.org. The guide offers tools and examples and case studies and resources and some of those critical success factors for implementing population health in a critical access hospital and small rural hospital setting. So I encourage you to check it out. It's a fantastic publication. I'm quite proud of it. In addition, we'll be hearing from from one critical access hospital in Louisiana who has taken the time to listen to their community through participation in the community health needs assessment process and received some really remarkable results to date. So I'm excited to have her share that impact with you today. So throughout this webinar series, we've learned about the critical nature of effective leadership and following a strategic plan, followed by the necessity to build a strong, healthy workforce that embraces and protects the positive work environment and culture. Now, with these tools in hand, we can prepare to connect with our community, our customers, and establish partnerships and collaborative relationships to really improve the overall health outcomes. Now, one of the primary goals of critical access hospitals, regardless of which payment structure they are currently operating in or preparing for, should be to capture their full market share. As the community specialist here at the center, when I conduct community health needs assessment, I see that many community members are unaware of the local healthcare services that are available locally. And part of the reason is folks just don't know that those services are available until they need them. And they perhaps likely assume that they aren't available in their local community, and so they drive to the next larger facility simply out of their lack of awareness. And I've seen anywhere from 25, 50, 75% of hospitals' market share within their service area are leaving the community, which is a huge detriment to the economic vitality and sustainability of the hospital, not to mention the rural community. So creating that awareness of which services are available is the first step. And now, traditional billboards and radio announcements don't typically do the trick with that. What is needed is really engaging the customers, the community, and partners. And one way to accomplish capturing that full market share is by excelling at customer service. Last week you heard from folks who spoke about the value of developing a workforce that is change-ready and adaptable. Having a workforce prepared to adapt to change requires leadership to view their workforce as a customer and provide orientation training and reinforcement of a culture that is person-centered and driven towards providing excellence in customer service. There are several frameworks, tools, models available to assist with excelling at customer service, some of which include Lean, which you heard about last week, which not only enhances workforce efficiency and productivity, but it also generates that positive patient outcome as it reduces that waste. For example, eliminating patients from having to answer the question, what's the matter, to every provider they encounter during the same visit. I know that I have had that at the hospital that I have been to. Each person I see, they're always asking me the same questions, and it gets annoying, and it's a waste of time and resources. Other frameworks and models that support excellence in customer service are participation in MBQuip through the HCAS patient satisfaction surveys, if the data is translated into action. Last week, I attended the Western Region Flex Conference, and we spent some time focusing on MBQuip and translating what those obstacles and opportunities were for reporting MBQuip data, as well as identifying those strategies of how are you going to take this data and translate it into action. John Peckham and his staff have kindly agreed to type up those responses from the small groups, and then those responses will be shared with the participants as well as shared in the Flex program forum. So I really encourage you to take a look at those once those are posted. There's some fantastic strategies available there. Other models include the AHRQ culture of patient safety, team steps, which I know a lot of those UFlex program are already implementing. Of course, there's Studer and their book, Hardwiring Excellence. If you haven't read that, it's a fantastic book and one that I strongly endorse personally when I'm traveling around in the community. And I can seriously tell within 10 minutes of visiting that hospital, whether it's a Studer hospital or not, meaning a hospital that is applying those Studer principles or not. And the reason I can tell is based on the happiness and the smiles on the faces of the staff, as well as the patients and the family members that are in the hospital setting. So it's a really great tool. If you haven't checked that out, I encourage you to do so. And in order to excel at customer service, it will really be helpful to be armed with these types of tools and models to help the navigation across that shaky bridge. The way I know that we've all seen this challenge, and Terry described this as well as Sally in the previous two webinars. And the way that I view this from the filter of looking at the community, customers, and population health perspective is that we're changing the conversation from asking the question, what's the matter, to what matters to you. And if you stop to think about the psychology of that, my previous background is was a psychotherapist in the outpatient mental health clinic, and so this was profound when it hit me that these were the difference between looking at the volume-based system that we're currently operating in, where we're asking the question, what's the matter, to the value-based system of what matters to you. Now keep this distinction of questions in mind as we think about how to develop that infrastructure on how to support the answers to these questions. I think the future healthcare business model, because it is based on patient value, we've got this new formula looking at what this means is that patient value, how we're going to get paid, will be determined by quality outcomes, as evidenced by federal participation with ACOs or MBQuip, plus service, as evidenced by value-based purchasing, HCAPs, patient satisfaction scores, community health assessments, and engaging in population health, divided by cost. And that will be the equation that we will be focusing on over the course of our transition. So how do you define population health? There has been some confusion with that because it's a complex issue, and we're operating under two different definitions sometimes because it's both of these definitions, and it's also situational. The most common hospital definition is looking at cohort management or population medicine, whereas community health or total population health looks at the entire group of individuals, oftentimes within a service area or a county, which is more public health defined. Some of those mechanisms to improve population include prevention, such as educating pre-diabetic patients on healthy eating or lifestyle to prevent diabetes, or perhaps monitoring or coaching diabetic patients to not escalate their symptoms. It's looking at quality and patient safety. For example, assuring that medical standards, such as administering an aspirin when symptoms of a heart attack are being demonstrated or met, as well as care coordination. Now that care coordination is about establishing those partnerships, perhaps between the EMS system, the hospital, and the long-term care facility, to ensure that patients' medical interventions are consistent. That care coordination component is the very large component to focus on. Now, up to this point, there's been very little documentation on how these mechanisms of population health have played out in rural communities. So what we did was we convened a critical access hospital population health summit. This summit has taken place, these types of summits have occurred annually for a few years. This one happened to be about population health, where we convened a think tank of rural health experts and experts in population health to create this guide identifying what can be done, what are those critical success factors for implementing population health. So some of those, I'll share with you some of those key recommendations, and then we'll hear from how Flex program and a critical access hospital are demonstrating this. So one of those key recommendations is that a change in perspective is going to be needed. So focusing on population health requires us to think differently about leadership. So as leaders in your organization, here's a few recommended attributes that will aid in this transition. So be person-centered, meaning keep the patient's skill sets and desired health outcome as the primary objective. Demonstrate that integrity. Demonstrate humility and willingness to collaborate, because you're, as a critical access hospital, they may not be the lead or of a community health coalition or the lead in finding what is most needed for that patient. Transparency of actions and demonstrating some honesty about results and progress, aims, defeats. And I think foremost, it's applying that systemic thinking and thinking holistically. And I really like this quote: if you don't help your community to thrive and grow, how will your organization thrive and grow? Another recommendation is to listen to the community. As a critical access hospital, help the public health department determine some of those health needs. Work with other types of organizations within the healthcare system and then translate, perhaps through a community health needs assessment, and then establishing those health priorities to really mobilize those resources, perhaps not typically found in the healthcare system. Another summit recommendation is to participate in collaborative relationships aimed at improving overall health. So look at local partnerships for care delivery. Create a commitment with local stakeholders to invest in health. Include population health strategies on boards, leadership, staff meeting agendas. I think it's not about the hospitals being able to fix all of the problems, but engaging with other leaders in their community to address these problems. So let's take a few moments to hear from Michelle Mills, CEO at the Colorado Center for Rural Health, on how her state flex program has applied some of these best practices in the component of customers, community, and population health. Michelle Mills, if I could have you hit *2 to unmute your line.
Great. I think I'm unmuted. Can you hear me?
I hear you perfectly. Thank you. And
Okay, great.
you also have control of the slides as well.
You do.
Okay, perfect. Thank you so much. And just wanted to say thanks for the opportunity to talk a little bit about some of the successes that we've had. I really appreciate it. So I thought I'd tell you just a little bit about who we are. And so the Colorado Rural Health Center was created back in 1991 as a 501(c)(3). And so we are one of only three offices that are State Office of Rural Health that are organized as a nonprofit. So that's both a blessing and a curse, but mostly a blessing that I am very appreciative of. Our mission is really to enhance healthcare services in Colorado by providing information and education and linkages to tools, and put energy towards addressing rural health issues to ensure quality of care out in rural Colorado. We have a staff of 21 full-time employees, so we're very lucky. And we also have 8 really active board members that come from EMS, rural health clinics. We have a physician, and critical access hospitals are those that make up our board. And in Colorado, we have 47 counties that are considered rural and frontier, with a population of almost 386 or 686,000 folks. So I thought I'd just start off really to tell you a little bit about how we do customer service with our critical access hospitals and our FLEX program. So in an effort really to provide that excellent customer service, we meet yearly with all of our critical access hospitals to conduct strategic planning, so that way we can ensure that we're developing programs and that are both needed and wanted. And who we sit down with for those meetings are the CEOs, the CFOs, and the quality directors. And I think it's really great to be able to have all of them together as their leadership team to sit down and chat with us. So based on that, we tailor our programs then to try to meet the rural needs versus offering an urban intervention that we just adapt into a rural setting. So part of developing those programs too is to really try to be nimble and flexible with how we administer them, again, to meet the needs of those we're trying to serve. So I have one example of how we did that, and a few years ago we offered out a Lean Six Sigma training where we utilized webinars and then Moodle to do education to make sure that they were learning all of the different techniques that they needed to learn for Lean Six Sigma. And then we used an expert to be able to coach and provide them support, so that way when they finished the webinar series, they came away with implementing it in a project and a green belt as a part of that. And so again, this was something they were able to then utilize with other projects within their facility. We try to relate our education and our programs to be on current trends and focus with both local and national level activities. So sometimes that means we have to push them a little bit, or potentially pull them along a bit in the direction that we know they need to be moving in, such as data collection. I'm sure you can all relate to that. We really try not to use trendy words like triple aim, and instead try to stress the importance of how their community needs to work together, and stress the importance of those that they serve. And we try to do that in a manner that doesn't duplicate services that are being offered by others, but offer out that education and assistance to meet really their needs. So I thought I would share one of the programs that we implemented as a result of this with you, which allowed our critical access hospitals to be part of both state and national priority areas. So that is our ICare Project, which stands for Improving Communications and Readmissions. And we started this back in 2010 because for years we've been hearing from the critical access hospitals that, again, they wanted to focus on something that mattered both at a state and a national level so they could demonstrate the work that they were doing. So we decided to focus on care transitions and avoidable readmissions. And I'm sorry, I have a little bit of a cold, so I have to take a little sip of water here. This offered us opportunity to align with what was happening statewide, national, and also funding priority areas for FLEX, which are core areas 1, quality improvement, and core area 3, support for health systems development and community. Sorry. So there's 29 critical access hospitals in Colorado, and we started this program with 9 of those participating in 2010 with the overarching goals of heart failure and pneumonia, which really represents the population that they're working on, and it doesn't duplicate data abstraction that they're having to do for hospital compare or MD-QIP. So my overall vision for this program is that it'll become a community-based program where rural health clinics, long-term care, EMS, schools, businesses, really anyone in the community that's focused on moving away from only chronic disease management, more towards health and wellness of the community. So we started this expansion in 2012 with the critical access hospitals provider-based clinics, and the provider-based clinics are focused on the goals through the lens of the diabetic population. And what we did was partner with the AHEX in our state where we have those critical access hospitals, and they do self-management, community training, as well as some linkages to other community resources such as community health workers and public health. So again, not trying to duplicate services, but trying to enhance the program through collaboration with others. We also asked both the hospital and the clinic team to come together to participate regularly in team meetings and webinars and education. So that way it works on that communication piece along with the chronic disease and looking at reducing the readmission. So these are the data that we collect both on the hospital and the clinic level. We ask them to collect these and then send this data on to us, but again, these are consistent with other data that they're being asked to collect, so it's not a duplication of resources. We have gone in the last year for the hospital readmission rate from 5% down to 4%, which normally when I talk about this to folks, they don't think that sounds like a big deal, but I know you guys can recognize that that's a huge deal given our small numbers. And then over the past year, the rural health clinics in the A1C measure have made 11% reduction in that measure. So we're starting to see some success, which is great. I just put up this list of accomplishments, which I won't go really through all of these because you've got them there. But one of the biggest successes, in addition to the movement on that data, is really getting more of the critical access hospitals and the rural health clinics engaged and involved in the program is really great. Also wanted to mention too that a couple of years ago, our state came together with 4 other partners to participate in what's called Healthy Transitions Colorado, and so we have a statewide goal of reducing the readmission rates by 20%. So it's really great. We're able to use this program to adapt into that as well. So our future plans, like I said, are to expand the ICare program beyond the critical access hospitals, like I said, to other entities that are involved in that care coordination piece. We just want to move it slowly so that way it's sustainable within each entity. And we also have to obviously seek additional funding to make that happen. But I'm excited that in the starting this fall, we're going to be engaging the public health and looking at engaging faith-based organizations as well in that work. So we try to also address population health through what we call HARC, which is Health Awareness for Rural Communities, and it's a data bank that we created as a way to engage critical access hospitals and other entities through data. So our HARC data bank is the first one in Colorado that solely examines the dynamics of rural and frontier counties. So as all of you know, rural community health needs are more often complicated than their urban counterparts, so we just wanted to ensure that we had appropriate and high-quality resources that were available to folks when they most needed it. So the HARC data bank is really designed to help examine the dynamics of the rural and the frontier counties through the use of quantitative measures and to sort and extract data in ways that help them make better decisions, and so that way they can use it also for strategic planning, because you all know when you've seen one rural community, I know you've seen one rural community. Additionally, we try to use it for other purposes as well. So I've got on this slide that we have over 100 population health indicators, and we're actually expanding that up to about 300. So we're hopeful to do a new release of that data here pretty soon. This is just to demonstrate how we're able to use our data. So these are statewide numbers that we produced, and we put it out in an issue brief, so that way statewide data on rural was available. We've also utilized this data for legislative education to help inform those conversations. And then specifically during the NRHA Policy Institute this year, we created a packet that was for each senator and representative with that data about their districts, so they could focus on education in terms of what is a critical access hospital, what is a rural health clinic, what is the population look like in their area that they serve. So again, I probably can't stress this enough, but collaboration is really key. All of the things that we do, we couldn't do as a standalone, and so we really believe on trying to form those alliances to be able to further our efforts. And it's fun when we do this, because you often find that people don't have enough resources either within their entity to do it. So it creates a really great alignment. So just can't stress the importance of that anymore. Thanks. Does anybody have questions? And I apologize for coughing all the way through that.
No, Michelle, that's really great. Could you tell me how long your ICare and the HARC database have been in existence?
Yeah, so we started our ICare project back in the fall of 2010, and so it's been going on 4 years now, and so that was really great. And then we just released the HARC data bank in May.
Okay, great. I'm impressed. It seems like you've achieved some positive health outcomes as a result of these programs. How quickly were you able to analyze that information on the HARC database?
It took quite a while. So and it was really great. So it probably took us about a year to get all of that data in a place that it was together, that we're able to pull out and analyze it. And so now we've got kind of all the programs in place that we're able to do that and pull it out fairly easily, but it did take quite a while to put it together. And this really stemmed out of the fact that we were doing community health needs assessments, and at one point we'd done, I think, like 19 or 20 of them in our state, and so we had all this data at our ready, and we said, gosh, we should do something with this to help inform conversations and use it to impact more things than what we're just doing through community health needs assessment. So that's where everything really stemmed from, but it took us about a year to get it together.
That's fantastic, and I'm so intrigued to hear what it will be like in the future after you have established some baseline data and been being able to see the impact over years of the hospitals developing initiatives based on those priorities that they've established.
Thanks.
What about any future plans for sustaining these programs, either ICare or the HARC database?
Yeah, so our HARC database is pretty easy to maintain now that we have it updated. So we actually have an intern in here right now, and so I highly encourage all of you to use free interns from your schools of public health or from your medical schools, because they are pretty eager to learn, and especially if you can offer something like data that they might be able to utilize if they're doing dissertations or things like that, or just presentations in terms of capstones. That's been very helpful. In terms of sustainability for our ICare program, obviously Flex is a huge piece of that, but we also have actively sought out additional funding to be able to add on those other entities. And then we recently started working with the RICOs in our area to see if we can form collaborations with them based on the needs in their areas, because their focus is on the Medicaid population, and so if they can help improve the outcomes in the regions that they're responsible for, they're pretty interested in that. And so we're trying to create alignments for that, where they would offer up some funds to be able to continue on projects to improve those outcomes.
Fantastic. I agree. I think those collaborative relationships are so key to that sustainability component. And thank you, Michelle, for sharing this information and telling us a little bit more about these programs. I'm thrilled to hear that it all stemmed from a community health needs assessment process. And another example of translating that community health needs assessment process is it's Claudia Wade, who is a grant writer with the Union General Hospital. She's got an example to share with us as well. So we have both the Flex perspective from Michelle Mills, and then we've got the hospital perspective from Claudia Wade. Thank you so much, Michelle, for sharing your stories. It was fantastic to learn about. Claudia, could we hear more about your stories?
Thank you very much. This is Claudia Way, and thank you to the National Rural Health Center for the opportunity to speak today about Union General Hospital's teen STD and pregnancy prevention program. It's a girl thing, making proud choices. Union General Hospital is a 501c3 critical access hospital in Farmerville, Northeast Louisiana. Sherry Banks and Jaime Brown from Life Spaces assist me with the clinical piece of the program, and they are here with me today too to share with all of you. It's a girl thing, making proud choices. Do I have control of the slides?
Yes, you do. There should be right and left arrows down in the lower left corner of the box.
I'm sorry.
No problem.
Okay. Our history. The program was created in response to a community health needs assessment funded by the Rural Health Performance Improvement. Thank you very much. The CHNA requirement applies to every hospital organization that has been recognized or seeks recognition under Code Section 501c3. The CHNA requirements are effective for tax years beginning after March 23, 2012. In 2012, we came together with our experience and background to offer It's a Girl Thing, Making Proud Choices to the community of Union Parish, and the program began in the fall of 2013. In less than a year, over 200 girls are enrolled in the program, and our team meets with the girls once a month at the hospital and every other week at the school. We also have a Facebook page, and we have over 500 followers, not only from Louisiana, but from all over the United States. And that's the way we stay in touch with the girls, and they call us, and they are very, very personal with us, so they know they can get in touch with us anytime they need anything. Our mission, the mission of the program, is to help change the views, circumstances, and lives of teen girls. And the goals of the programs are to connect and educate with teen girls aged 12 to 17 with a focus on pregnancy and STD prevention while utilizing educational activities, health information, and comparable testimonials from influential community leaders. The information is provided to teens for use of tools to guide a process of understanding the importance of self-worth and setting goals in life. Peer involvement with like situations are also very instrumental for the development of the program. The objectives of the program are to provide knowledge, enhance decision-making skills, and change attitudes and beliefs about self-worth. The learning outcomes of these programs are that the girls will be able to safely explore the consequences of their sexual health choices. The girls will be able to identify how sexual health choices made while they are teenagers can affect them for the rest of their lives. The girls will be empowered with knowledge to make healthy choices, and the girls will be able to analyze how their sexual behavior can affect for the rest of her life, not only their life, but any person around them. Among the program topics, we talk about self-esteem, learning to respect themselves and others, dating and dating violence, their reproductive system, sexual health, consequences of teen pregnancy, sexually transmitted diseases, what happens when pregnancy is going wrong, sexual abuse, how to be responsible, etiquette, finances, nutrition, drug prevention, bullying, dating violence, and much, much more. We have included some of the participant quotes from some of our girls because we evaluate the program every 3 months. And these are just 3 quotes from the 200 girls enrolled in the program. And they say, this program has made me a better person. I am learning that I don't have to change for anyone and to be myself. I'm sorry. It's a girl thing. This is Alicia B. And it's a girl thing, making proud choices has taught me to say no. From Carolyn K. I see myself now making good choices. Jasmine. It is better to be safe than to be sorry. I am understanding self-worth. Destiny. Union General Hospital is partnering with Life Faces Consulting for the development of It's a Girl Thing, Making Proud Choices, and is eager to share the program with other hospitals and the community. If you need more information, please feel free to contact me, send me an email, or give me a call. Thank you very much. If you have any questions, please feel free.
Great. Thank you very much, Claudia. Could you share any challenges or lessons learned you have faced with developing and implementing this program?
Sure. Implementing this program has not been an easy task, of course, although it's not a challenge either. I think the time we have put into it has been, I'm sorry, I'm from El Salvador. I speak English and Spanish, so sometimes I get messed up with my pronunciation, but it's part of it. That's the way we got all the Hispanic community involved in the program. And yeah, I think the time we have put into it has been the only thing we have to get accustomed to. We are all very dedicated to the program. It's our passion. It's not a job. It's more than a job. It's a passion to help our teen girls. But due to the fact that we all have full-time jobs and other obligations, that adjusting our schedules were definitely something we had to deal with in the beginning stages. As a result, it's now second nature to us, and we have all taken on ownership of this program in it as our own personal responsibility.
Yeah, that's great, and it's very evident that you have some passion and excitement towards this initiative, and I think that's what makes it so successful as well, is when you're excited about this and you say that it's not a job, it's something that you're eager about, that translates into the girls that you're able to impact, and the results are clear that that's the case. Could you describe some of the benefits you have seen from partnering with other organizations through this program?
It's been wonderful. The community, it's been really wonderful. And the benefits of partnering with other organizations has been the broad community resources and awareness. There are many facets of communities and legal, healthcare, and educational resources benefited Union General Hospital by adding to our endeavor. Other than the obvious input from the resources, we find we reach more young people utilizing partners. For example, one of the grocery stores in the area had a young team that worked for them, and they were a big sponsor. Therefore, she was motivated to attend the sessions and become interactive in this program. The local library reached teens we were able to serve because they were regulars at the library and encouraged to attend our program as well. And we have been supported tremendously by the school board. And we are also creating a book club, the teen book club, and so the girls can be, busy during the summertime. So it's a key. I mean, we have to have, for a program like this, the community support. We need to look for partnerships.
Yeah, that's fantastic. Just reinforcing what we heard earlier from Michelle Mills, that collaboration aspect and really reaching out to the community and building those partnerships is key to, like you had said, indicating that positive relationship for your hospital.
Oh, yes. Every month we have businesses donating door prizes, grocery stores donating the food sometimes, the drinks, and I mean, everybody's very involved in the community. We also have girls coming from other parishes now, and they have been calling us, and they have been driving the girls and getting their own buses, and I mean, the word has been spreading out, and the program it's growing fast.
Wow, that's impressive that the grocery store is even contributing to this initiative. Could you describe some of the impact you've seen from engaging the community towards improving the population's health?
Well, we are improving the population's health merely by educating in a supportive nature. The girls are being educated and informed on how to receive HPV vaccinations. Many girls were not aware that they could or even needed to get the vaccinations, perhaps. And we're being able to teach the girls about their menstrual cycles and the linear equations of normalcy and abnormal, therefore helping them receive medical care if they need to. Perhaps a teen suffer from undiagnosed depression and have suicidal thoughts, and was referred to counseling, and this teen had not come forward to her parents or educational support systems before we met her. The intimate nature of exploring teens' sexuality is at all times forming a trust and a bond where they feel they can ask us any questions or anything they want to know. And it's going to be confidential. The teen health also improve as it becomes clear to them the risk of STDs and pregnancy and how to avoid that.
Sure. Yeah, it sounds like one of those key components is really focusing on building that trust and loyalty within the girls,
Yes.
and having them be able to come to you as confidants and know that they're going to be respected.
Yes.
Yeah,
That
I can.
they
I
have
can see that
expressed
really can
didn't
contribute
have
towards.
before.
Pardon me.
That is one of that they told us that they didn't have this trust in anybody, not a family member, not a friend, nobody before.
That's powerful. What
Yes.
an important role that you have served with this. With that customer trust and loyalty that you've established, I can envision that this is a program that will not only help the hospital sustain and capture that full market share, at least with the younger demographic here, but what are your future plans for sustaining this program, because it has been so successful? It would be great to be able to continue it.
Well, our future plans to sustain the program is to remain dedicated and persistent to our girls, because they count on us to be there for them as role models and bridges to bright futures, to implement more activities and programs that are geared to teens in our communities, and to share these programs with hospitals everywhere so that we can reach more girls. And by reaching more girls, we all can participate in helping with changing their views, circumstances, and life, so that they can grow up to be successful, respectful women with a purpose, and that will allow all of us to experience better futures.
Yeah, that's great, and it's so nice to hear that a hospital is taking the care and investing the time and efforts to pursue such a project that they had identified through their community health needs assessment process. That's really fantastic.
Thank you.
Yeah.
It's been wonderful in General Hospital.
Yeah, and I'm assuming that we've got a question here. Does this program take place at the hospital, or is it just sponsored by the hospital?
We have a big meeting once a month at the hospital. That's our main meeting. And then we meet with the girls every 2 weeks at the school. And we have the book club at the library on Thursdays.
Okay, thank you.
We meet, the main meeting takes place at Union General Hospital's conference room the last Monday of each month.
Okay. I see we've got another message coming in, but while Carol is typing, I'm curious, how much approximate financial contribution has this been an issue at the board level, or have you had any resistance from staff members about wanting to prioritize this as an initiative, or what does that look like?
Not at all. It's been the program. It's just part of us. Nobody's been reluctant or anything. It's flowing, and it's something that we really need to improve health in the community. And it's not only something that is affecting Northeast Louisiana. It's affecting everybody.
Sure. And does the hospital fund this project solely, or are there additional funding sources?
Yes, the hospital fully funds this program.
Okay.
Union General Hospital is fully funding the program. And we have some donations and of supplies, and some business make contributions with food and anything they can, door prizes, but mainly it's funded by the hospital.
Okay. Is this through the hospital foundation or the hospital?
No, it is the hospital.
The hospital. Okay. Great. Well, I would love to keep chatting about this more with you. Is this,
I get excited too. I understand the feeling.
Yeah. It's a project that I could...
I love the subject, by the way.
Yeah, totally. I'd love to stay in touch with you and learn more about what your program looks like in a couple of years or even a year from now, and just keep tabs on you and be able to share that with the folks on the call as well to see how great of an impact you will make over the coming years.
Sure. It will be an honor.
Great. Thank you so much, Claudia. I appreciate your time and expertise and sharing your passion and drive for helping these girls and developing some trust for them. That's really fantastic.
Thank you for inviting me to be part of it.
Yes, thank you.
Thank you. Bye-bye.
Bye. So Carol had asked a good question. Is the hospital funding this project, and what does that, what would that look like? So as a result of the Population Health Summit guide that we have created, I've got a few slides here just reinforcing what a critical access hospital can do. And we've got a few key points here that I'd like to take a few moments of your time to share with you. And you can access this information again on our website at ruralcenter.org. Check it out. There's some really great examples there. But foremost, it's building that case for population health, really creating that awareness. I think alignment with mission and values is not typically enough. We need to be able to align and put that value-based reimbursement structure. One of my favorite quotes from the summit was about discussing that hospitals are being asked to sort of self-sabotage by keeping people away from their services in this new reimbursement model, but that's not just about doing the right thing, altruism. It needs to find that financial case for your critical access hospital and framing the conversation in terms of charity care or bad debt or meeting that community benefit that we had explored through Claudia Wade's facility. It's also identifying that impact on other priorities, taking a look at those care transitions through the ICare program that Michelle Mills talked about. It's also about putting population health on the agenda and reviewing some of that claims data from the payer's perspective to be able to identify what the service area priorities. I've included a list of 4 questions here that as Flex coordinators, if you'd like to share those 4 questions with your critical access hospitals to help stem a conversation, those are good questions to help them prioritize and determine what they can do to address their population health strategies. Another suggested recommendation is for critical access hospitals to look inside their own walls and apply a worksite wellness program. There is an example of a critical access hospital that took a look at all of their employees, and after 2 years, the hospital has seen they took a look at their employees that had multiple
chronic illnesses. This is in Mason District Hospital, Indiana. And after 2 years, the hospital has seen nearly $360,000 in reduced employee health care costs, and has started offering the program to local businesses, which both improves health locally and provides an additional revenue stream for their program because they've reached out to their community and they've really role modeled what that wellness looks like. So there's some great examples of positive work that is happening out there. Another recommendation is to reach out to that community. It's just to really establish those collaborative relationships and partnerships. That's really the theme for today is connect with your community, your customers, and your partners. Articulate those roles and responsibilities and think beyond your traditional partners. I think another aspect is to be patient. A lot of this is going to take time because what we're doing in essence is changing culture. We're changing that culture from the illness model or the volume-based model of asking what's the matter to what matters to you and the population health-based patient value reimbursement system. So what I'd like to give you a little cheerleading here is to start where you are, use what you have, and do what you can. All of you folks, flex coordinators and Federal Office of Rural Health Policy employees, you are the change agents, and you're able to provide that technical assistance and that support to these critical access hospitals to help them improve the health of the community. And what a fantastic opportunity it is to be in that position right now while we're designing what this looks like in our states and in our critical access hospitals and in our rural communities. And if you've got examples of great work that is happening in your states, I'd love to hear about it. We'd love to showcase it on a future webinar, on the virtual knowledge groups, on our Flex Program Forum, other speaking opportunities at national and state conferences. We just want to be able to identify those, share those best practices so we all don't have to reinvent the wheel. We can listen to each other and form those collaborative partnerships. And I'd also like to invite you to participate in our upcoming event. We have an applied exercise. Our second one is due on Monday, June 23rd at 5 p.m. Central Time. That applied exercise is available in Moodle. If you need